so very much for being with us here today. My name is David Griffith. I'm the Director of Programs and Outreach for the Lgbt Elder Initiative. So I want to welcome you to today's Doctors In program, this month looking at the topic of cancer screenings. As many of you know who've come to some of these programs before, the Doctors In is a program, a health series that we started back in the spring as a collaboration between the LGBT Elder Initiative and Jefferson Health. So through the support of some initial funding from the Jefferson Center for Urban Health, and then through the time and energy and expertise of the geriatricians from the Jefferson Department of Family and Community Medicine who are providing these presentations. I would now like to bring up Dr. Cooperman.
Thank you. Hi everyone, thanks for having us here. I also have Dr. Salzman, who's another one of the geriatricians, who I think many of you have met before. So we're gonna be talking about cancer screenings today. These are the topics that months back, we had sent out a survey to see what you were interested in learning about and hearing about. So we'll keep doing that every month, and if there's things that we're not bringing here and we're not talking about, let us know. We want to know what you guys are interested in. So we'll begin. Let's start with your participation. Who in this room, let's do it with a raising that hands, who in this room has ever been affected by cancer, yourself, with somebody that you know? Wow, yeah. All right, so I think really all of us have been affected by cancer. Cancer is something that affects us in some way or another, and so an important topic and something that I'm really happy to be able to come and talk to you all about. So what is cancer? Let's see if this will work.
Cancer is the name given to a whole range of diseases caused by uncontrolled cell growth in the human body. Cancer can affect anyone because we are all made up of cells. Trillions of them working together. When these cells become old or damaged, they stop growing or are destroyed. New cells then reproduce to replace them. Normally, this destruction and growth of cells is kept in balance. But, very rarely, the controls that stop individual cells from reproducing fail. A damaged cell, instead of being destroyed, may start to divide uncontrollably, forming a lump or tumour in the human tissue or organs. If these cells are able to continue spreading, the tumour is known as a cancer. It can grow unnoticed or begin to affect the normal workings of the body. Some cancerous cells can break away, travelling through the blood or lymphatic system and causing secondary cancers in other parts of the body. However, not all cancers form tumours. When blood cells grow uncontrollably, they spread gradually in the blood as a leukemia. And with so many different cell types in the body, many forms of cancer can develop. Cancer is not a modern problem. A tumour was described in a medical textbook from ancient Egypt. And Hippocrates, the father of medicine, seeing blood vessels stretched around a tumour, first named the disease using the Greek word for crab.
All right, so just a little bit about what cancer is so that we're all on the same page about that. And then today I'm going to talk a little bit about cancer statistics in our country, about cancer risk factors, about screening tests, which is the main part of the lecture, screening recommendations, and then hopefully get some time to tap into coverage for screening tests and additional resources that you all can have moving forward. So cancer statistics. So this talks about cancer statistics. Something that I do want to mention here is that in our country, the way that we collect cancer statistics and data in general about these diseases is based on two biological groupings, male and female. It's absolutely not the way that the majority of people in our country or in the world identify, but right now this is how we collect the information. So especially in the beginning of the lecture when I'm talking about the statistics that we do have, I'm going to use these two categories. hopefully as the lecture goes on, we can talk a little bit more about decision making for the individual, and I can give some more individualized information to you about that. So this is the new cancers that were diagnosed in the US in 2018. And you can see on the left side here is the male cancers and the female cancers. Prostate cancer is the leading diagnosed cancer in the US and for men, and then breast cancer for women. They both are followed by lung cancer and colon and rectal cancer. And then we have the actual deaths from cancer. And you can see that actually the lung cancer is the cancer that causes the most amount of deaths in the country, followed by prostate and breast cancer, and then colon and rectal cancer. So there are lots of cancers out there. Lots of people are affected by other cancers, but those are the ones that, that cause the most amount of new cases and deaths. And then here's cancer statistics in our country. This is in 2015. This is by age. So I think this is important here to see that the majority, the highest amount of new diagnosis of cancer happen in the age group 65 to 74. And that's followed by 55 to 64 and 75 to 84. So cancer diagnosis happen in the older adult population more than they do in younger adults. All right, cancer risk factors. Can a person prevent cancer from happening? What do you all think? No. No. You're all right. So cancer is not preventable, but we know that there's things that you can do to reduce your risk for cancer. Any ideas of things that one can do to reduce the risk of cancer? Diet, I like that. Exercise. Screening. Stop smoking. I think, yeah, sleep adding to overall rest and health. I think that, yeah, staying healthy. You guys got a lot of them, yeah. Where you live. Oh, yeah. All right, I think you guys got a lot of them. So staying away from tobacco, staying at a healthy weight, physical activity, eating fruits and vegetables, a healthy diet. We didn't mention this one, alcohol, limiting the amount of alcohol that one drinks, protecting your skin. So skin cancer, getting vaccines, knowing your own risks, knowing your medical history, knowing your family's history, and then getting regular checkups and screening tests. So here we are with that. So some cancer screening, so getting into the cancer screening test. Not the easiest question, but do you all know how we define screening tests or what screening tests are? Yeah.
When I found out I had prostate cancer a year ago, I think it's because the PSA level, mine was like 16, and she detected it was high, and they sent me to different specialists. I went to Hammond Hospital, Feinsteinville, and they helped me for 3 months with radiation and everything, and I'm grateful for that because it scared me, you know, and everything, and the other things that go after that when you have side effects and everything. And when it's like, I had 3 months, I had my radiation, came up there, went there, did 3 months, everything was no fine. I go to the bathroom one day, fight myself, it's blood, and that's a symptom, that's what they call that, but it's a symptom, and I went through that for 10 months of that. And it wasn't for the doctor he did 2 colonoscopies where he seen that they put so much radiation on one side, it like scarred it, like a cut. Yeah. And that was doing the thing. But when he did the 2 colonoscopy to close it up, thank God it stopped 20 months ago.
Wow. Wow. Thank you for sharing about that. I'm sorry that happened to you. But I think you get it with some, so you were talking about a PSA, and we'll get into all of the different tests. So screening tests, something, here we can, so screening tests are tests that we do before a person has any symptoms or before they would feel sick. So it's something that can be done with certain cancers for people when they're at the right age, which we'll get into. And sometimes what they can do is they can detect cancers at an earlier stage when we can actually do something to help that cancer, to treat the cancer. And sometimes this better treatment can make it so that a person's less likely to die from the disease, not always. And so you mentioned one of the screening tests. I think you actually mentioned two. You mentioned a PSA, which is a prostate-specific antigen, and you mentioned a colonoscopy. So two of them. Any other screening tests that you all can name that you've heard of before?
A prostate screening test.
The prostate screening test, Mammograms, right? There is skin testing, yeah. So here we have a lot, yeah, go ahead.
I just want to say, well, other things testing they was testing for, they took like 10 biopsies. When I went in one day, they asked for that. They did it, MRI, and also they did I can't think of the name. But they did that.
They did that, yeah. And I think some of what you might be getting to is that sometimes so screening tests we like to do, it's a screening. It can look at somebody who's otherwise healthy and doesn't have any symptoms, and it can tell us that there's a chance that there could be disease present. Some of the tests, things that you're talking about are once we've already had a positive screening test, some of the other tests that we do to find out more information, to give treatment, things like that. Go ahead.
Blood count also, that would also help with the screen. That's when they found preset of myelofibrinosis for the bone marrow biopsy for the blood test.
Yeah, so and I don't talk about blood tests here, but blood tests are something that we do routinely, even in healthy, people who don't have symptoms sometimes, and they can lead us to a place in a way that screening tests can, that say, wow, something's off here, we need to do more testing, which I think is a great way to think about screening tests. It doesn't say a person has the cancer, has the disease, but it gives us a flag that something's a little bit off and we need to look more into it. Some of the other ones you all mentioned was mammogram, which is our screening test for breast cancer. Colonoscopies, stool tests is a screening test for colon and rectal cancer. The PSA, or the prostate-specific antigen test, is a test for prostate cancer. Then we have CAT scans, which are the choice screening tests for lung cancer. And then we also, one that we didn't talk about was, or mention, was Pap smears or HPV tests for cervical cancer. Yeah, in fact.
Why is it recommended that women, young girls, get mammograms at age 30 and above, as opposed to 13 and above, or when they start blooming?
That they get mammograms, or?
Yeah, mammograms for cancer.
We can talk more about the specifics of mammograms as we go through. It's not my understanding that young girls do get, that it's recommended that any young girl who's 13 gets a mammogram. Usually we start mammogram screening later on. Sometimes in a specific person there might be other risk factors that a doctor could say that might be recommended. But does that answer your
Her question was, why wouldn't you?
Oh, why wouldn't you?
As soon as they're breast tissue.
Oh, okay. So why wouldn't we start when they're 13?
Oh, yeah, like I said, they recommend that women get a mammogram at age 30 and up. Why not younger?
Okay, I see. Sorry, I misheard you. So, and we'll talk about the recommendations that it's usually 40 and up, but the way that screening tests are is that we usually don't start screening until there's, until a person's more likely to develop the cancer. So young women are not very likely to get breast cancer. So we don't start screening until they're at the ages when breast cancer develops, but it's still early enough that there's interventions and there's things that we can do to help that cancer. So, and kind of as we'll get into this, screening tests are great because they can give us information that's really useful, but sometimes screening tests give us information that can mislead us down a path of lots of interventions, lots of surgeries that for the young girls, for instance, they're not very likely to get cancer in those young ages. So to put them through a screening test and potentially other surgeries or other procedures that would be unnecessary, we don't do it. Is that? Yeah.
I want to ask you a question.
Yeah.
What is the recommended age for a young girl? I'm going to piggyback a little bit on her question. For HPV testing, at what age?
Oh, so why don't we, right now we're going to get into each one of those. I think you guys are getting into exactly what I wanted to communicate with you guys is our recommendations. So there are a lot of and we talked about, you had brought up skin testing for skin cancers, and there are other cancers that we know people have in this country and that we may have had loved ones who had suffered from, but routinely we don't do screening for these cancers. And I think that's important to remember, unless sometimes people have certain symptoms and then we do more tests to look and see if they might have these other cancers, but they're not included in our routine screening. So let's get into some of the screenings. And I think important to keep in mind here that I've tried to make this as broad as possible, as general as possible in terms of our recommendations about screening. Again, this is an individual thing that conversation and decision to make with a primary care doctor, with one's family. And so this is all the recommendations in our country for a person who has no symptoms right now and who is at average risk of getting these cancers. These recommendations do change if someone's having symptoms or if somebody in their family had one of these cancers or something like that. So let's start with breast cancer. So kind of getting at what you were saying. So the screening test, like we mentioned before, is a mammogram. And a mammogram is a type of x-ray of the breast. It's done in the outpatient office, so it's not something that anybody has to go into the hospital for, but it is something that you do outside of your primary care doctor's office. And a lot of women talk about mammograms. They can be uncomfortable, sometimes even painful for people, but they are short, and so I think that's important to know. They don't take a long time. And then the overall guidelines, depending on which organization you look at, is to start them around 40 or 45 years old, and recommend that women get them either yearly or every other year. And then starting around 75 years old, that's when we really encourage individuals to talk to your doctor, to talk to your family, and to hear about the risks and benefits of going on with mammograms after that age. Questions on mammograms or in breast? Yeah, go ahead.
What's the risk involved?
What's the risk? So, risks can be different things in general, and this is the truth for a lot of these screening tests. The risks are that sometimes we find, sometimes the screening test can be positive. It can look like there's something going on, and it's not actually cancer. And so then a person would end up getting the mammogram, but then having to go down a long road of stuff that's pretty stressful, emotionally stressful to think one has cancer, but then didn't end up having cancer. There's surgeries that are involved, like getting biopsies and seeing specialists, even having to go to the doctor week after week to get this look into this positive screening test. That's a lot of the risk factors. Obviously, there are always benefits to things, and sometimes we do a screening test and we see a positive result and it is actually positive, and it was a beneficial test. But as we get older, and I'll keep bringing this back as we get into each of the different cancers, as we get older, there tends to be more risks associated with these screening tests and maybe not as many benefits.
Now, with the guidelines, of course, it is hereditary in the family, mothers, sisters, and all. those are the people who would want to be getting more screenings than the regular lump.
Exactly. Did everybody hear that? Yeah. So with family history, it can really change the recommendations. And so you brought up that in families where there's a lot of breast cancer, that people might get screened more frequently for longer periods of time, maybe even earlier on than these recommendations.
So getting back to the first question, so in other words, the risk is that as we age, there's more likelihood that we would get a false positive?
Correct. Especially with mammograms, right? That's, yeah.
Yeah, women are more likely as we get older to have false positives, meaning we have different lumps and bumps that the mammogram will say is suggestive of cancer and ends up not being cancer. So we tend to detect more lesions that wouldn't affect a woman's life expectancy or life.
Let's go here and then we'll take it. Yeah.
Are the X-rays themselves dangerous?
The extra, I mean,
It's considered, a mammogram's considered a very low dose of radiation.
The tacticians always hide the lead sheet.
Absolutely, there
yeah,
certainly
no, you're
is.
right. Yeah, there's always
yeah.
some risk associated with getting X-rays
It doesn't
done.
encourage women to do that.
Right, I know. You're like, wait, you're getting that, but I'm sitting here with my body out, and
There certainly is some radiation exposure, and that they, certainly if you're working there every day, that's why they cover themselves up. They're thought to be in low doses that are safe for the screening recommendations, but that is one thing that we consider why we might get it every other year versus every year.
absolutely. And some women actually find it really uncomfortable. So it's not a risk that we all, not necessarily life or death, but it's an uncomfortable position to be in.
What about self-breast exams or clinical breast exams?
It's a tough question. It's the recommendations now are that we're not doing breast exams. That being said, I did say that these all has to do with people who aren't having current symptoms, and we know that when individuals find a lump or a bump that's unusual in their breast, it is important for them to talk to their doctors about it. And yeah.
I want to know I want to know in urban areas like major city populations, there are numbers of people, thousands of people in New York City, thousands of people in Chicago, Los Angeles, I'm calling them out right now. But you have all these populations of people. Now, the high concentration population of persons, of people in that city, do you think there's a higher rate of breast cancer because of the high populations, like people living in New York City and people living in Los Angeles or maybe in Chicago and Philadelphia and places like that? Do you think because of the population, so many folks, you think that's a greater risk because of that?
I don't think living in a city is a greater risk of getting breast cancer. I think that cancers happen in our population, and if you have a place that has more people, there's going to be more cancers because there's more people, but I don't think that it's a risk factor in itself to live in one of our populated urban areas. All right, so prostate cancer. So again, this is the PSA, or the prostate specific antigen. It's a blood test, and it's done in a lab, so it's something that your primary doctor could either do in their office, or if they send you out to like LabCorp or one of those other labs, they would do a blood draw for it. And the guidelines are basically around between 55 and 69-year-olds. So it's recommended that it's an individual decision that you make with your primary care doctor, and to be thinking about benefits and harms of screening. So, and then so that's sort of a gray area, I guess. And it's one that's been changing over the past years. Even last year, we were told by the organizations in our country that we shouldn't be recommending prostate cancer testing. And now we're being told that we should offer it, and that each person should make a decision with their doctor about it. We do know that at this point, when a person becomes 70 years old, we're recommending against getting the PSA blood test because of the amount of false positives and the fact that any treatment wouldn't be necessary in terms of affecting a person's life, their outcomes, I guess. Yeah.
Very briefly, what causes prostate cancer? Is it inactivity?
No.
I don't think that's, I think prostate cancer it gets a little bit beyond my complete scope, but it's just like all of the cancers in our body, that there's cells there, and if they start growing in ways that aren't the normal growth, they develop cancer. But I don't think it's different. It's not use it or lose it type of cancer. That makes sense. Yeah, absolutely. I think it's a great question. I think it's a great question, and it's something that when I was doing some research and when we've been looking, it's something that I do see a lot of people asking. So I think you're right to ask the question. So that's prostate cancer, cervical cancer. So I think somebody had asked about cervical cancer. So cervical, and I think you were asking about HPV testing in particular. So there's two types of screening tests that we do for cervical cancer. One is a Pap test or a Pap smear, and the other is an HPV test. So they're both done in like an outpatient office or clinic, and they're done with a speculum, which is either the metal or the plastic tool that a doctor uses to look at inside the vagina, and they're both just samples that are taken from inside, past the vagina and the cervix area. And the Pap in itself, or the HPV test, is one that we start using once individual becomes 30 years old. So we start screening with the Pap smear at age 21, and then once someone's 30, we do the Pap smear and the HPV. In general, we say that if a person, around 65, we can stop doing the screening. But that has to do with has the person had several years of normal Pap and HPV tests in the past, so that would be one reason to stop at 65. And another is if there was a person got a hysterectomy, the uterus removed with the complete cervix for a reason that had nothing, that didn't have to do with cancer, something like fibroids. So those are two reasons that we might stop screening at 65. In terms of how often we get it, it's usually in the population of 30 to 65, it's every 5 years, and that's if the doctor's using the Pap plus the HPV test. Sometimes in individuals, a doc might not use both of those tests, might use one of them, so it's a little bit of an individual basis. Somebody had a question? No. Yeah.
So do you have total hysterectomy? It's not recommended, it's no need to?
So, and that gets into a tricky part of it. It's a total hysterectomy with also the removal of the cervix, which is the opening of the uterus. So sometimes individuals get hysterectomies, but part of the cervix, that part of the opening of the uterus, is left inside the body. And those people, we do continue to get Pap smears and HPV tests, but yeah.
You say they stopped taking tests of people for cancer at 65, but would they take it if a person get older than that and supposed to get sick? Can they, y'all let them get sick and die?
It's a good question.
You mean for the Pap smear?
Do you mean just the Pap smear?
Yes. For all that, when you go 65 and y'all not getting tested no more, so but for something is wrong with that person,
yeah,
you know, find out that he's sick.
Yeah. So the 65, each one of these cancers has different age cutoffs that we usually recommend. Not necessarily stopping, but it's a a time to talk to your doctor about if it's right to keep on screening and if it's not right. And a lot of this has to do with sort of what Dr. Salzman was saying before, that a lot of times we have false positives in these tests, and sometimes even if we were to find a cancer, it might not actually affect a person in their lifetime. The cancer might not affect them in their lifetime. And so getting a screening test on a cancer that may not actually do anything to harm the person in their lifetime might not make sense. And that's, I guess, a quick way to say it. It's not a quick conversation. It's not a quick thought in itself. I don't know, Dr. Salzman.
And I'll just add, just as Dr. Cooperman said, that the screening tests are for people who don't have symptoms. So anyone who has symptoms, that's a different story. You should talk to your doctor and see what tests may be indicated. So we wouldn't want someone to wait till they're really sick. If they had a symptom, let your doctor know. What's that?
Yeah.
Yeah.
Yeah, I think that's a good point. Like if somebody's feeling really sick, always to talk to your doctor about feeling sick. All right, so colon and rectal cancer. There's lots of tests that we do for screening for these cancers. So you had mentioned colonoscopy, a sigmoidoscopy. Those are one-day procedures. They're usually done sometimes in the hospital, but as a same-day procedure, you don't necessarily spend the night. And that's when flexible, I can say little, but the camera is put into the rectum to look at the rectum, and for the colonoscopy, the rectum and the entire colon. There's also stool testing, and stool testing is something that one does at home, collects samples of stool, and sends it into the lab. And in terms of guidelines, usually we recommend around the age of 50 to start screening for this type of cancer. And the timing really depends on which of these tests one is getting. So the stool testing, we recommend that a person does that every year. And then with the colonoscopy, the sigmoidoscopy, that's usually more of a every 5 years, every 10 years, and kind of depends on what the results were in the past. And then this one is one that around the age of 75 is when we recommend that a person talk to their doctor about the risks and benefits of continuing with this screening. Yeah.
Can you speak to garden cell? What's the purpose? I know, because I know that's when the part with HPV and all that. But is that recommended for young ladies, or is it recommended for men? Because I heard there's one for men also besides garden cell.
Yeah, we recommend that for all kids, starting at, I'm forgetting the age.
I know. It's 9 to 11.
9 to 11, yeah. So yeah, and it's prevented. Yeah. So and that links to cervical cancer for sure, but it's a vaccine. So and you're right. That's like kind of what are the things. Remember in the slide earlier, what are the things we can do to reduce the risk of getting cancer? And that's one of the vaccines that we do recommend.
Question on that, really piggyback off of that part. Is it more than one dose of that vaccine? Is it a follow-up? But what if the child only had just the one and never did the follow-up?
So it's a complicated answer. It depends on how old the kid was when they got their first one, and so I think that's a case by case, but these are good questions.
Your doctor can catch you up.
Yeah.
Like if someone started it, don't worry. Like let your doctor know they can finish the series.
Yeah.
But
even if there's been more time than recommended, as doctors we can, like Dr. Salzman said, catch you up. Okay.
Yes, well, I don't know what a sigmoidoscopy is. I know what a colonoscopy is. I'm not sure what sigmoidoscopy is.
Yeah, so sigmoidoscopy, it's similar in terms of what the actual tool is. It's a flexible camera, but instead of going, so it goes into the rectum area, but it doesn't go throughout the whole colon. So it's a smaller camera. Mm-hmm. Mm-hmm. There was another question over here. Yeah.
Mm-hmm. Now, I've been hearing this on the television lately about these kids getting HPV for the kids. What is that for? Something because of they go into puberty or what? What is it? It's prevention.
Yeah, And I think you're talking about similar things to what we were just talking about over here. So HPV is a virus, and we do have vaccines that can protect against a lot of the strains of the virus. There's many types of the virus, but we have vaccines that protect against a lot of them, and so it's a vaccine that we recommend to kids to protect them in their life from being exposed to.
So like, I'm assuming that you do it when the child comes into puberty. Okay, so
We usually do it a little bit before puberty as a way of protecting kids before they start becoming sexually active. And lung cancer. So lung cancer, the screening test that we use is a CAT scan. It's an X-ray machine, and it's gonna use low doses of radiation to look at the lungs and to put a picture together of the lungs. And the guidelines is that we do this yearly, and we start in individuals who are 55. But it's not every individual. It's somebody who has had a really significant smoking history. So in medicine, we use something called a pack year. So somebody who's been smoking 30 pack years. So somebody who smokes 1 pack a day for 30 years, or something like 2 packs a day for 15 years. And so it's people who have smoked a lot. So that's why it is really important. This is, going to your doctor and being really honest about what if you've been smoking or not. Let me just finish this and I will get to you. We test anybody who's currently smoking, or even if somebody's quit, if they quit within the past 15 years, we still screen them with this every year. Once a person hits the anniversary of 15 years without smoking, we stop doing this screening.
You had a question?
My dad had lung cancer.
I can hear that.
And he died in 2006.
I'm sorry to hear that.
He stopped smoking though. He stopped smoking 10 years before that, before he got lung cancer.
It's so hard because we hear about this and we're always encouraging people to stop smoking because it can really help their overall health, and we hope that it really can make it so that they don't have to get cancer. And we do know that quitting smoking does improve your day-to-day health and also can make you less likely to get lung cancer. And that's why we say after being smoke-free for 15 years, they don't have to get these yearly CAT scans. But obviously there's individuals who it didn't happen for, and so it's so hard.
It's hard.
Yeah.
Right. Okay, it's like the word lung cancer. Of course, my grandmother got that by second-hand smoke. But my brother, on my father's side, he caught lung cancer for volunteering for 9/11 with the asbestos and all. So of course, cigarette smoking is not the only way of getting lung cancer.
Yeah, absolutely. That's a big, important part. And in this, I'm talking so much more about person's risk based on their smoking history, but it is important to also talk about the things that we do for our work, for volunteer, things that we've been exposed to when we talk to our doctors, so that they can kind of take all those things and give us good recommendations for to screen us for things. Yeah.
I was going to say, well, I'm just grateful that my cousin Gary seen 4 lung cancer, which is so that I'm grateful for that. So now I understand what you're saying. That you really don't have to smoke as a kid lung cancer. I've never smoked in my life.
Unfortunately, there are types of lung cancer that can happen even if we don't smoke. Absolutely.
And, I'm sorry, and also, and from some of the suburban neighborhoods where they talk about the smokestacks and the radiation plans, they're worried too, because they're afraid, even with the environment, that stuff is seeping in the air and they can get in their lungs. Or a coal miner in West Virginia who's in the coal mine can get it also. So there's a lot of ways. You're right. I'll think back on Adele. You can get it a lot of ways. Yeah.
Absolutely, and that's that's why it's never silly when a doctor says, like, tell me about you, where did you grow up, or what do you do in your spare time? It's good to share that information so that they can tell you, you know what, that's not it might look like a lot of smoke or something like that, but it's not something that can cause cancer, or like, wow, that could cause cancer.
I'm going to ask about the same thing that radon, which is a gas that comes out of the ground in the basement sometimes. In some areas it's not, but some how much of it is probably in Philadelphia?
I'm not sure about the answer to that. I'll be honest, I don't know if it might be something that we'd have to ask somebody who has more expertise in radon. Yeah.
Just saying, I'm not trying to be nasty or anything like that, but I seen my doctor today and he asked me, Charlie, you still having sex or anything? I said, no, which I ain't. But over the years, when gay men get with other men and they have sex, I'm not trying to be nasty. From the anus, you know what I mean? Destroying. And when they have that, when you do that so many years, and the doctor, do they test you for that to see if you have built some type of cancer for that or something else? You get what I'm saying?
Yeah, I mean,
I want to ask somebody that question, but we talk about it, but we don't say that in front of everybody. You say it to your doctor, if you get what I'm saying.
Yeah, absolutely.
You know what I mean?
I mean, certainly we know the HPV virus that causes cervical cancers can also cause anal cancers as well. We don't have currently, there aren't recommendations at this time for anal cancer screening in that way, like a pap smear, but it is certainly something that one is why I think the HPV vaccine is important for us to get to help prevent cancers for men and women. And certainly if you had any anal lesions or concerns, to let your doctor take a look or to know about.
Yeah, that's a great question. So we've sort of been talking about this throughout as I've been talking about the recommendations, but do you think we should get screened forever?
Yes. I want to go now.
I don't know if my point across in the right way. So screening is so important, and it is important to get screened, but it's not something that we encourage people to do forever. And this kind of gets into, I mean, each different cancer is different in terms of the ages that we recommend that a person start thinking about not screening. We know, and this is, I think I've mentioned this throughout the lecture, but screening tests can save lives, but they can also cause harm. We've talked about what some of those harms can be. As you get older, some of these tests don't necessarily give us the accurate results. They give us these things called false positives, and that can lead to more testing, more bad side effects. So it's just something to think about. They're not, because they sometimes give false positives, a person can get told, wow, your mammogram this year was positive. You need to go and do this and this, and a person can get like more worried and think that they have cancer when they don't have cancer. And they can lead to things like biopsies, surgeries that a person might not want that are unnecessary. So it is possible that a doctor might recommend that you stop screening for some of these cancers. And so how do we know when to stop screening? I can't tell you right here, right now, at this time, at this age, stop this. But I do, based on those recommendations that I was giving before, at certain ages, and even before, I recommend that when you're having these conversations with your primary doctor about your general health, about cancer screenings, that you ask them questions about this. Make sure that when you're talking about this, you talk about what your history has been. If you've had any cancers before, if there's any cancers in your family, things that you've been exposed to in your work or just in your personal life. In general, talking to them about what your personal wishes are. And I really encourage you, we're geriatricians. We often have patients who come and see us and they bring family members, they bring friends, they bring people who are in their lives who they talk about this stuff with. And it's something that I encourage you to do. Bring the people that you trust the most with you to see your doctor when you're having these conversations. Because I think when we have those we love and trust, they can help us to really understand what our personal wishes are. And then just always asking yourself when it comes to these different cancers, would you get further treatment of a certain cancer if you were diagnosed? And thinking about that and asking the doctor, what would treatment look like? So those are just important things to consider. Questions about stopping screening? Okay. So I did want to talk about the LGBT community and cancer. And this is, some of what I was talking about earlier on about statistics. It is important to know that the LGBT community, there is over 1 million cancer survivors in the community. And there's a disproportionate, greater risk, a greater cancer burden in the LGBT community. And that's not necessarily because cancer affects people in the LGBT community more, but often cancer is diagnosed at a later stage. And that's not for everybody, but it is something that we know happens. And it's not because of certain biological factors. It's not even necessarily because of certain practices. A lot of it has to do with health disparities that we know to be true that affect the LGBT community. And that has to do with having a doctor that you feel safe going to, having a doctor that asks you the right questions about yourself. And so I do think that, this could be a lecture in itself, just on that. Something that I think is really important, there is an organization called the National LGBT Cancer Network, and it has a lot of, I have the website here, but it has a lot of resources for the community about cancer, about getting diagnosed with cancer, treated for cancer. And I think one of the things that they have is they have a tool that's called Take Care of That Body. And in that, there's a risk assessment kind of calculator. And so it looks at, it asks questions. You can go on, you answer the questions yourself. And it's not just how old you are or what race you are, but it asks questions as to what gender do you identify as, and then asks about certain body parts that the body parts that of the cancers we're talking about, breasts and prostates, and it asks, do you have breasts? Do you have a prostate? And how old are you? And then from that, it gives recommendations as to what screening tests would be recommended. And it also has a whole tab that has screening facilities to get these cancer screenings in each city that would be a safe place to have these conversations with a doctor. And so I do encourage not only thinking about the ages and risk factors we were talking about before, but to go through this and to make sure that you tell the doctors about these things about yourself. We've got 2 questions. Go ahead, and then we'll get to you guys.
I don't hear very much talk about men having breast cancer, but I'm quite sure some do or whatever. And what is the stages of that? Can you tell us the stages, the symptoms or something?
Yeah. So you're right that breast cancer in men is not as common as women. So we don't routinely screen for breast cancer in men, but this kind of gets back to what Dr. Salzman was saying before, is that there are symptoms, and so having pain in the breast area, having growth in the breast area, those are all things that I would bring up with a doctor.
Give it back off of this, but if the family all has breast cancer or whatever, but now you have to avoid. Now, are they have to get screened just the same?
So it's not necessarily the same, but you're right that men who are in families where there's a lot of the genetic breast cancer, they may be screened in a way that a man who's not in that family would. And that's why often in families where there's that much cancer, we recommend sending them to a genetic counselor to help to make those decisions.
Can you flip back to the web address again?
Certainly. It's www.cancer-network.org. Yep.
I want to be very clear on one thing here. Philadelphia Fight, I'm not calling organizations out, and other organizations in the neighborhood, but there are organizations that are LGBT. Organizations that are affirming with care, specialize in trans care. Okay, Mazzoni's one, for example. And so you have to kind of shop around to see which kind of care you want in this LGBT community, because a lot of times people will choose some kind of care outside and it's not sort of connected to who they are. So I think that's important. That's one step at looking at LGBT care as far as for yourself. And then don't feel that you're restricted. That's another thing I'm going to say in the LGBT community, because you can always have your primary care physician at Philadelphia, but you can also see somebody who's home. So don't feel you're restricted. You can go around, you can shop around in all these areas.
I think
that's good tip to everyone.
It's great. We have good resources here, and important to be at a place that you feel safe and comfortable. You feel like they are giving you the care that you need.
Just wanted to ask you, are the cancers that people get in their extremities similar or different from the ones that are in your organs that we talked about today?
I don't know if I think, I'm not sure how to answer.
I mean,
there's so many different types of cancer. They all stem from the same thing that we were talking about in the beginning of cells that make up, each of our organs and our parts of our body having overgrowth. So they are similar in that kind of way. Sometimes cancers show up as tumors. Sometimes they're in the blood. So the symptoms might be different. The treatments might be different. Does that answer your question?
Yeah, I'm just curious, because you hear about people who have limbs removed because the cancer is just in their arm or their leg. And it just seems so unusual compared to the majority, which are in organs or blood.
Yeah.
But if you think about the tumor being in the breast and having the breast removed, it's almost the same concept.
Yeah, that's true.
I think during the 80s, my mother had breast cancer. And since technology is a little bit more advanced than it was then, they took the breast off. Well, certain things she had got chemo, her hair fell out, and she had to wear a wig. And, I just thank God that, technology has really advanced. Because I think they could have just took the nipple off and took the lymph out and on her arm, and I think she would have lived.
Yeah, it's hard to speak to it, but there's, different breast cancers have different treatments. Sometimes it's just a small amount of the breast is removed, sometimes the entire breast, sometimes some of the lymph nodes around it. So
she did have a lump.
Yeah.
And what happened is, my mother was concerned. Okay, she had the lump removed. But the doctor told her she had to take the whole breast off. My mom said, why take the whole breast off? You just took the lump out. And I think what happened is, once they took the lump out, I think the cancer spread. That's what happened. And they took the whole breast off, and then the house started to go down and left it.
Yeah. There was another question that I'd seen. I think we're needing to wrap up somewhat soon. So let me just say that one other thing that I wanted to make sure to talk about is Medicare and coverage for these tests. Medicare usually does cover these tests. There's often if you pay a copay, they can charge a copay, and then they may not be covered every single year, and some of that has to do with how the recommendations are. So always talk to your doctor, talk to your insurance to find out the specifics if it is covered. And then some other resources, I included the one that we had talked about already about the LGBT Cancer Network, but some of the other internet resources. And something to always remember when it comes to your health and the internet is that the internet is never the same thing as getting medical advice from your doctor, from your nurse practitioner, from somebody that's actually in the healthcare field. Always looking at the webs. I put some ones that we know are trusted here, but always looking at the website, seeing who's putting the website up and knowing where you're getting your information, seeing how current it is. These recommendations about cancer change a lot, yearly. So making sure that you're getting up-to-date information. All right, I think that's the cancer. So questions? I know there's a couple more questions, but I think we're going to wrap up in a few minutes. Okay. Okay. Yeah.
When men have breast cancer, do they go through that effect? They have operation to take some of that out, or the whole round circle of the man, upper, you know what I mean?
Yeah. So I think it depends on kind of what we were talking about before, on the cancer, on how much it's spread, the extent of it. So I think it depends. But yeah, there are sometimes surgeries, sometimes the chemotherapy, the radiation.
Okay. I'm also an advocate for melanoma mind or whatever, so I go to a lot of their seminars and stuff. But the thing is to know yourself, to know your body, that if you have a lesion out there that looks kind of different and odd, go right to your doctor and tell them to check it.
Absolutely. And I don't talk enough about skin cancer in this for how much we see skin cancer because we don't have a routine test for screening, but anything that looks abnormal, it's always better to bring it to the attention of a doctor, have someone else look at it, for sure. Yeah.
I just was wondering about why they chose certain times when you couldn't get tested for a certain exam. I think you said something about that you might not be covered at certain times for cancers. And what, as the gentleman was saying, what if at the time we really need it? Is there any other option?
So I think that's a great question. If Medicare or your insurance isn't covering a screening test, let's say you really need it. So this goes into having symptoms. If there's ever something that seems off and you have a change in anything or a symptom, that's different. It no longer is a screening test, and that's something that would be covered because a person's doctor would be looking into that symptom. So absolutely should never, if you just had one of these screening tests a couple months ago and now you have a new symptom, should always bring it to the attention of a doctor and never think about the cost of it. It's a very different situation. Great question.
So is it true that surgery sometimes does increase the spread of cancer?
Surgery does increase this one. I think it's specific. It's not like any surgeries. There are surgeries that we get to remove cancer.
Surgery for cancer, so like to remove a lump. That by doing that surgery that you're actually increasing the spread of that cancer.
I think that it can be sometimes something like that could happen. I do think if one's considering surgery for a cancer, that would be a good question to ask the doctor. Depends on kind of where they're doing the surgery, what type of surgery it is, what kind of cancer it is, how it's appeared in the body. So I think those would be good questions to ask. All right. Well, thanks for joining us today.
So again, thank you very much to Dr. Cooperman and to Dr. Salzman for sharing their expertise with us today. Give them another round of applause.